And we dive straight into the first case, which is being presented by Dr. Swapnil Parchand, who is a consultant in Retina and Uvea at the MGMI Institute in Raipur and is actually an alumni from PGI. Dr. Swapnil, please, if you would share your slide. And he will be talking to us or showing us actually two cases in which retinal vasculitis was actually the harbinger of sinister systemic pathologies. Dr. Swapnil, please.
Good morning, everyone. Dr. Mohit, my slides are visible?
Absolutely, sir. They are.
My voice is clear?
Very clear, sir. Please.
So I'll go on the first case. He's 42-year male, farmer by occupation, and he presented with blurring of vision in both eyes since 2 months. It was gradual, painless, and progressive. On examination, his visual acuity was 20/50 in both eyes. He has few cells in anterior chamber, and he has vitritis. On fundus examination, what we can see is there are multiple retinal hemorrhages. Few of them are white-centered hemorrhages all over the posterior pole. There is retinal vasculitis involving the larger vessel. And importantly, what we can see are a few yellowish white granular retinal infiltrates in perifoveal area. Apart from that, we can see this, there is macular edema. So we can see clearly this granular retinal infiltrates. So if we see periphery, there is extensive retinal vasculitis associated with retinal hemorrhages. A similar picture was present in left eye also. This is the periphery. On OCT, what we can see is there is presence of macular edema. There are pinpoint hyperreflective lesions within the inner retinal layer, and these were corresponding to this granular retinal infiltrates. Similar picture was there in OCT in left eye as well. So clinical diagnosis at this point was posterior uveitis, retinal vasculitis, mainly hemorrhagic periphlebitis, along with macular edema. So differential diagnosis, what we can suspect is Behçet disease, tuberculosis, blood cell dysplasia, and sarcoidosis. So on retrospective history, this patient gave history of significant weight loss in last 6 months. At that point of time, we started on topical drops, prednisolone and nepafenec, and we investigated this patient. So on complete blood count, what we can see is HB level is less, the total leukocyte count are quite high, and DLC is quite deranged. Platelet counts were normal. So peripheral smear was suggestive of chronic proliferative disorder, possible CML. On ultrasound abdomen, it was suggestive of grossly enlarged size. Spleen was grossly enlarged with normal shape and equal texture. So he was referred to hematologist for further evaluation. Hematologist prescribed bone marrow, and bone marrow revealed features suggestive of myeloproliferative neoplasm, suggestive of CML on chronic phase. And they also did BCR ABL quantitative analysis or peripheral blood with RT-PCR, and it was again suggestive of CML. So hematology started on allopurinol and hydroxyurea. So this was as presentation, and over a follow-up, his visual acuity subsequently improved to 20/20 at the end of 2 months. His retinal hemorrhages started disappearing, and as well as his retinal infiltrates. So this is my second case. He is again 42-year-old male, presented with sudden painless loss of vision since 1 week. He also had loss of weight and appetite for 3 months. On examination, per abdominal examination, he had hepatosplenomegaly. This is fundus picture. What we can see is floric NVD, neovascularization of disc, a few scattered retinal hemorrhages over the posterior pole, and we can appreciate retinal vasculitis as well. And mainly, if you see nasal part of retina, we can again see similar kind of granular retinal infiltrates, which are actually looking like a clumps. This is picture of left eye showing NVD, vasculitis, and retinal hemorrhages. So again, this patient also had low HB count, and his TLC was quite raised, DLC was deranged, and peripheral smear again was suggestive of CML. So if we see the literature, there are not much reports which present CML or retinal infiltrates as a presenting feature of CML. This is one of the publication series of patients of leukemia published in ophthalmology. Out of 38 patients of CML, only one patient has leukemic retinal infiltrates, whereas none of the patient reported as retinal vasculitis. So what we can gather from both of my case is that vasculitis in CML is mainly involving the vein. It mostly is hemorrhagic periphlebitis. It involves large as well as small vessels. They have dense perivascular cuffing. They are associated with granular retinal infiltrates. We can see NVD, and of course, we rod spots are pathognomic of leukemia. So thank you for your patient hearing.
Thank you, Dr. Swapnil, for those two excellent cases. I think they were very well documented, and I think they were crisp, and they drove home the point that you wanted to talk about. So thank you, sir. If you would kindly stop sharing your screen, and I'll just throw this up, this open for discussion to the panelists, please. I would like to, get Rajan sir in first, and ask for his views on these two cases, and also pose a query to him. So some of these lesions might look like CMV retinitis lesions, and patients with CML might have CMV retinitis also, whether they are treated or they are treatment naive. So how can one look at maybe clinically or otherwise differentiating, or any other clues or pointers that one might be astute to, sir?
Yeah, very nice presentation, Swapnil, and you have brought out a very important point that whenever you have a bilateral presentation of multiple hemorrhages, sometimes they look like CRV also, in the sense lots of hemorrhages. But if you see very carefully, why should a patient develop bilateral picture like that? And when you may have sometimes some venous tortuosity, and those very fine yellowish white lesions which you mentioned about granularity, those should immediately raise suspicion of a blood dyscrasia. So any blood dyscrasia can cause. In fact, the more common ones are the CML and sometimes AML. Uh, Very rarely you may have to consider even anemic retinopathy, but they usually won't have too much of that kind of intense hemorrhages which you have noted. There will be more like blood hemorrhages. They may have white centered hemorrhages. But again, the important point that you have brought out, the message is, whenever patients present with bilateral picture of, let's say, a CRV or a venous stasis, it should immediately alert you to a systemic disease and not just do an OCT and keep treating with anti-VEGF injections. But coming back to Mohit's point, again, when you see too many intense hemorrhage, like in CMV retinitis, you will see retinitis patches and some hemorrhages depending on the type of CMV retinitis that you are seeing. But when you are seeing more hemorrhages, bilateral, almost symmetrical with venous congestion, that means there is a venous, coagulopathy, or there is a blood dyscrasia going on. If I can share my screen actually at this point of time, I would like to show some images of mine. I'll just, yeah, so I hope you can see my slides, and these are some different variety of cases. I mean, this is not exactly the same way your patient has presented, but sometimes you can have infiltrative optic neuropathy. This is a patient of AML actually, and both has no light perception. So this is one variety you can see. Then the other variety is that, like, you can see this lots of hemorrhages, but again with an optic nerve infiltration again, but with hemorrhage. So whenever you have infiltrative neuropathy, you must consider a systemic pathology and not just treat them like you would otherwise treat them with anti-VEGF sometimes in these cases. Again, look at these hemorrhages. A lot of them have white center in them, but the hemorrhages can have varied presentation, like the one you showed, and they may have periphlebitis kind of picture, but the hemorrhages are not the typical CRVO kind of hemorrhage that you will see. This is the other eye of the patient. Again, you can see disc infiltrate here. But then I will show you one more case. Yeah, so if you see here, this patient also has a lot of these white centered hemorrhages, or those granularities, not just white centered hemorrhages that you can see. And you can see in the blood vessels also, there is some perivascular infiltration. So these are the cases. This patient actually turned out to be having CML. But again, any patient where you see there are no other risk factors for a CRVO, bilateral presentation, and there are many hemorrhages with white center or some granularity, those should immediately raise suspicion. And you did the right thing actually. So the message to the audience is that don't look at every patient as something which can be treated with anti-VEGF injection. Always dive deep to find out what could be the cause of these occlusions. Even BRVO, actually I was surprised in one case in a conference in Israel where they showed bilateral BRVO. I mean, patient is normal hypertensive diabetic. We see bilateral BRVO, one eye at one time, another at another time. But again, that patient they showed had a leukemia. So you must be alert. Just rule out. There's no harm in ruling out and doing a peripheral smear in these cases.
Absolutely, sir. Thank you, sir, for those for sharing your screen and showing excellent cases as well. I'll now, like to throw this out to Ramandeep, sir. So you have a lot of experience, and I'll just little bit, off the topic of adult CML, but you also deal with a lot of pediatric leukemia cases, sir, with your collaboration over the years with the Advanced Pediatric Center patients. And if you would just like to share your experience regarding and a few pointers as to how we can maybe pick up, cases earlier in the pediatric age group, sir.
I think most of the points Dr. Raja has covered, but nice slide by Dr. Raja and Dr. Swapnil. But one thing which reminds me, the eye is the window of the human body. This we must all remember this thing. There are certain signs which we see in the eye, and we can somehow predict that this is what the systemic diseases can be there. So adding a simple test like CBC in these young patients, like Dr. Raja said, in the bilateral and with the lots of hemorrhages, with the with the venous stasis type picture, and in the kids, like the Mohit said, I'll come to that point straight away. In the kids, the greatest worry is there. They are on immunosuppression, and the pediatrician is worried that whether it's an infectious disease is occurring or it's a infiltrative disease occurring, and that is the clue there. So, like so the presentation can be of an infiltrative optic disc disease, like Dr. Raja showed. If you moment you see infiltration in the disc, then you have to tell the pediatrician this is a recurrence in the brain, so you must go for it. And then if you see these hemorrhages with NVD with subhyaloid hemorrhages, you miss that subhyaloid board-shaped bleeds. In that paper, the board-shaped bleed is one of the is a sign there. So if you see those signs, it's probably due to the disease per se, and it is not due to the infectious. And CMV, once you see CMV cases, you will never miss it in these eyes, because it is certainly a different picture. You will not see these white-centered hemorrhages scattered all over and venous stasis. So I think it's clinically you can make out most of the things. Mohit, I hope I've answered all the questions.
Absolutely, sir. And Sangeet, sir, any point from you regarding this? Any treatment related nuggets that you'd like to give after we have diagnosed, sir? We have, the most important point, as was brought out by the panelists, were to find the underlying cause. But after we have found it out, is there a role for treating it with anti-VEGFs or with steroids or anything else along? I mean, of course, primarily treating the patient for the underlying disorder, or do we hedge our bets and just first try and get the hematological parameters in under correction and delay treatment as far as the ocular features are concerned?
Yeah. I think my primary thing is to treat the disease per se rather than treating the retina at this time. But I don't know, I may do a FFA to see any ischemic areas are around or not. And if there are any ischemic areas, might do some laser also. Anti-VEGFs, I don't think will have any role because it's not a occlusive disease as such. One more thing I'd like to add is sometimes leukemia can also present as a frosted branch meningitis. One case I remember, he had a very severe frosted branch meningitis in both eyes, which turned out to be leukemic infiltrates along blood vessels. And that is another presentation which can be there for leukemia. But the one thing that Dr. Raja has also pointed out, and Swapnil has also pointed out, is that bilaterality in the disease often suggests that it's a systemic underlying cause, whether it's an inflammatory or whether it's a neoplastic or anything. And we have to investigate for that and not just go ahead and treat with anti-VEGF.
Thank you, sir. Thank you for those.
I think FFA would have been an additional investigation in these.
I would like to add that first case actually did had a bleed on subsequent follow-up. He was lost to follow-up, and then he again presented with vitreous hemorrhage. So I did a vitrectomy, and post-operative, of course, I did a laser, and post-operatively I did a FFA, which was suggestive of a lot of CNP areas in other eye as well. So I did a laser PRP in other eye, and this side underwent PPV.
So one interesting point, if I can add, Mohit, it's related to COVID. I had one young boy who presented like a month ago, and I think Apurva has also raised an important point. We'll come to that. But 1 month ago, he came with his father, and then when I saw he had bilateral kind of CRVO picture, and I was like, this has to be investigated now right away. I have to take him to the physician. This was like what we are discussing now, and I will make sure that he has a systemic disease found out right now. I mean, they did not give the history of AML at that time. And then gradually started asking more questions. What happened? Why did he have any problem earlier? Then he showed me a bunch of papers, and in that it was written AML, and the last chemo he took was last year. And then my enthusiasm fell down a little bit that, I did not diagnose, he's already diagnosed. But then the point was that due to COVID, he missed 2 cycles. And his father was saying, the last time we did his CBC was all right. Ye dekhiye aap, his leukocyte count. I said, that was like 4 or 5 months ago. But then we picked up that he needs, he has recurrence probably, and then he needs to be sent to the oncologist again, hemato-oncologist. But then after that, he has not followed up again. Very unfortunate. All these things, whenever they are leukemias, COVID, it's, at least as an eye center standalone, it becomes very difficult to coordinate with everyone. But then this can be, as Ramandeep pointed out, that you need to be very careful. Even if it's a diagnosed case, we may be able to tell what's going on with the body before they even present to the oncologist again for further checkup. So that's an important point that I wanted to make. So Apurva, you can go ahead probably with your comments.
Yes, sir. Just like I said in my comment, many of our PDR patients, I don't know if I should say many, but some of our PDR patients seem to have CML as well. And these patients have a much more florid PDR and much worse membranes, who have a lot more bleeding than usual. And we fail to see sometimes that these patients actually have clues of some dyscrasia because of the atypical hemorrhages that they have, which we see intraoperatively carefully, which we have cursorily seen and passed away as PDR. And ever since we've had some 2-3 patients and burnt our fingers, we are doing a peripheral smear in all our PDR patients. And even the vitreous hemorrhage in these patients, it's not red, it's ochre yellow. I don't know if the panelists have similar observations to make.
Yeah, very important point you have raised, Apurva, in the sense the PDR patients can have leukemia and CML basically. And what we see in these patients is the numerous hemorrhages that they have. Unlike some PDR patient, we see that, they will have some dot blot hemorrhages, NVD, NV. But these kind of patients, what Swapnil showed, if you see that kind of massive hemorrhages in these patients, again, they may be having also white center and some perivascular exudation may also be there. But whenever you suspect a bilateral, you are not sure, is this CRV or PDR kind of doubts when you start having, please do go ahead for CBC peripheral smear. We are not generally going in for, in general, CBC for all PDR patients, but whenever we have suspicion, we are going in for that. So overall, I think you have to look at the clinical picture, which you have raised. A very important point, Apurva, that you cannot just assume and imagine every patient of PDR has only PDR.
One more thing I'd like to add to what Dr. Apurva has pointed out is that she has burnt fingers. I had also burnt my hands doing the PDR and leukemia, which were together in 2 patients, I think I remember.
Yes.
Are so thick, they are so attached to the retina, you cannot, it's not possible to separate them. And 2 patients I lost just because of this, and I've now stopped patients who have both the things together, diabetic retinopathy as well as CML. I've stopped operating them now when I've burnt my finger. You're absolutely right. It's very difficult to operate.
Absolutely. Ashish, are you ready with your presentation? Thank you, everyone. Thank you, Purva, for the comments.